Hello. Hello. Hello.
Sir, good morning.
Hello. Good morning, Praveen.
Yes, sir. Yes, sir. I'm audible, sir.
Yes, yes, you are right.
Okay, okay. Okay. So, press link I have shared with you, sir. That is working. The previous link I have shared, that link is not working, I think.
Okay.
Yeah.
Okay, not an issue, Praveen. हेलो। सिस्टम का नहीं आता इसमें ऑडियो, दिक्कत है। हेलो। सिस्टम ऑडियो नहीं आता।
Yes, sir. You are audible. Your voice
हाँ
is
नहीं,
echoing.
आई एम जस्ट चेकिंग द साउंड हियर। ओके।
Yeah, charging. Point.
स्पीकर शायद वो वाला चाहिए होगा आपको, AMX वाला।
नहीं नहीं, ये सेम कर दो उसमें। हेलो।
नहीं, इसमें तो ठीक है, जो कोई ज्वाइन करेगा ना।
तो आ जाएगा इसमें। आ जाएगा वो और बार तो बता।
क्या लगाया, उल्टा लगा, उल्टा लगा। नहीं, सीधा 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 ही लगेगा, ये कई बार इसमें गिर जाता है। ठीक, कोई दिक्कत
ये तो लगाओ प्रेजेंटेशन से।
नहीं।
अब मेरे को प्रेजेंटेशन इससे दिखेगी। तो मूव कर रहा है, इसको ठीक करिए। खाना तो मूव कर रहा है।
सेंटर स्टेज है।
प्रो कैमरा, टेस्ट व्यू कैमरा है क्या? नहीं नहीं हुआ। मुझे लगा सर वो मैकबुक टेस्ट व्यू कैमरा हुआ।
ठीक है, आगे भी हो रहा है। यस सर।
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. So today we have a presentation on congenital anomalies of kidney and urinary tract. And this will be presented by our resident, Dr. Devashish, and would be moderated by our faculty, Dr. Rajiv. So I request Dr. Devashish to kindly share his presentation. Yes.
Good morning, respected teachers and my seniors and my colleagues. Today I will be presenting on anomalies of upper urinary tracts. The anomalies of upper urinary tracts, respecting the kidneys and collecting system, can be classified as renal number anomalies, renal position anomalies, fusion anomalies, rotation abnormalities, vascular and collecting system anomalies. Coming to the first anomaly, bilateral renal agenesis. It is congenital absence of both the kidneys and it occurs due to failure of ureteric bud development bilaterally, and it is almost uniformly lethal. It is seen in 1 in 5,000 births, and it is more common in males, and there is increased familial risk. In embryology, there is failure of ureteric bud formation and induction of metanephric blastemas, and the defect has to be on the both sides to have this situation. Here we can see in the image the ureteric blood and the metanephric blastomas. Now, the bilateral renal agenesis consists of absent kidneys, absent or athertic ureters, and hypoplastic bladders, normal adrenal positions. Now, it is associated with a Potter sequence, and in this there is bilateral renal agenesis and bilateral multicystic dysplastic kidneys. There is reduced fetal urine excretion leading to oligohydramnios. And there is a characteristic facies known as Potter facies. Here there is low set ears and big nose, prominent epicanthic folds, and downward slant of eyes. It is associated with pulmonary hypoplasia and limb deformities. Bilateral renal agenesis, the prognosis is very poor. 40% are stillborn, and the live births die within 24 to 48 hours. And experimental amnio infusion treatment is being given. If some survives, they require a lifelong dialysis. Coming to the second anomaly, unilateral renal agenesis. It is absence of one kidney, and it is non-ectopic solitary functioning kidney, and it is often an incidental finding. It's seen in 1 in 1200 live births, more common in males, and it is more common on the left side, and it is an autosomal dominant with variable penetration. It is classified by Maggie embryologically into 3 types, 1, 2, and 3. The primary defect in type 1 is in ureteric bud fails to form. In type 2, the Wolffian duct abnormalities are there. In type 3, the ureteric bud forms but fails induction. Kidney is absent in all 3. Ureter, there is a blind ureter present in type 3 and it is absent in both type 1 and type 2. The Wolffian duct is abnormal in type 2 and in other 2 it is normal. The genital abnormalities are more common in type 2, and it is in type 2 we see a specific syndrome known as OH-Vera syndrome. It is associated with various other anomalies like the VUR in 30% of the cases, and UPJ obstruction, bacterial associations, and reproductive anomalies. Unilateral renal agenesis in males are associated with absent vas difference, seminal vesicle cysts known as Jenner syndrome, cryptorchidism. Here is a radiological image showing absence of right renal right kidney. The second image is showing a seminal cyst, and the third image is showing a dilated ejaculatory duct. And this triad is a Jenner syndrome triad. Now, the unilateral renal agenesis in females are associated with other anomalies like unicornate uterus, didelphys uterus, OH-Vera syndrome, and MRKH syndrome. The OH-Vera syndrome is also called as Herrlin-Werner and Undelis syndrome. And here we can see an CT image showing a right renal agenesis, and it is seen in Meyer-Rokitansky-Kuster-Hauser syndrome type 2. And it is, you can see there is absence of the uterus in the second image, the sagittal T2 weighted MRI image. Now coming to the third anomaly, supernumerary kidneys. They are two accessory kidneys. They have a separate capsule and an independent blood supply. They are usually, the supernumerary kidneys are smaller than the normal kidneys. They are often caudal to the main kidney, and the ureter are duplicated, or they may have a common stem. Now, in this radiological image, we can see in the first image, these are the supernumerary kidneys. Here it is the caudal kidney, and they have a two different blood supply. You can see the above kidney is supplied a branch from the aorta, and the lower kidney is getting its arterial supply from the left iliac vessel. And again, you can see this in this axial sections. This is the upper kidney which is getting supply from aorta, and this is the caudal kidney which is getting supply from the left iliac vessel. The clinical importance of this anomaly is it is usually asymptomatic, may cause obstruction or infection, and they are usually incidentally diagnosed. Now coming to the renal ascent abnormalities. The ascent occurs from 6 to 9 weeks of gestation, and it is associated with 90-degree medial rotation. And they reach a final lumbar retroperitoneal position. Now in this diagram we can see, to start with, both the renal ureteric buds they are close by and in the pelvis, and they gradually ascend through 9 weeks. They get separated and they ascend upwards and reach the supraadrenal glands and their retroperitoneal position at the lumbar region with medial rotation in the final image. Now coming to the first anomaly, it is simple renal ectopia. There is failure of ascent of a single one-sided kidney, and the kidney remains ipsilateral, and it is most common position is the pelvic position. The incidence is 1 in 900 live births, and there is no major gender difference in these anomalies. We can see here it is an ultrasound image of a 5-month-old male showing an pelvic kidney in the below image, and you see this kidney is just below the urinary bladder. Hence, we can confirm the pelvic position. Again, this is a coronal image of an CT showing a pelvic kidney in a 93-year-old male. So you can see they are not they're incidentally diagnosed, and the simple ectopia, the common complications associated are hydronephrosis, most common, UPJ obstruction in 50% of the cases, and VUR in 30 to 50% of the cases. Now, the other variety of the simple ectopia is the thoracic kidney. It is less common, about 5% of the ectopia. It is seen in 1 in 13,000 live births, usually asymptomatic and diagnosed on chest imaging. Here we can see a right side subdiaphragmatic kidney. It is high up in a 53-year-old woman. The second anomaly is the crossed renal ectopia. The kidney crosses the midline, and the ureter, however, comes back and crossing the midline and is inserted in the normal position. It is the second most common fusion anomaly, and 90% of the cases in this are fused. Both the kidneys are fused, and left to right migration is the more common variety. Now, there are various types of crossed renal ectopia. First is the crossed renal ectopia with fusion. Second is without fusion. The third one is both the kidneys seem to be appears to be a single kidney, solitary kidney, and there is bilateral crossed renal ectopia. This is the fourth variety. Here both the kidneys cross, however the ureter come back to their normal position. Now, in this image, we can see a crossed renal ectopia. The left kidney has migrated to the right side, and the second image is showing a 3D reconstruction of the same person. You can see the ureter coming back to the normal position. Now, this crossed renal ectopia variety again can be divided, sub-classified into further 6 classifications. One is inferior crossed fusion and S-shaped fusion, one forming a lump kidney, one forming a L-shaped kidney, one forming a disc-shaped kidney, and a superiorly crossed fusion. Now, complications associated with the crossed ectopia are VUR in roughly 20% of the cases, obstruction, stone formation and recurrent UTIs, and variable vascular anomalies. Now, coming to the third variety is the horseshoe kidney. Here there is fusion, incidence is 1 in 400, and here there is fusion of the lower poles, and there is a low position as the ascent is obstructed by the inferior mesenteric artery, and it is usually associated with malrotation. Here you can see an ultrasound showing a fusion of the lower poles in a 10-week-old infant. This is an axial CT section showing a horseshoe kidney. The lower poles are fused here, and this is a 3D reconstruction of the same person showing a horseshoe-shaped kidney. Now, one variety of the horseshoe-shaped kidney is a pancake kidney, where it appears to be a pancake, a disc-like structure. The clinical importance is it is usually asymptomatic and associated with UPJ obstruction. There is an increased risk of Wilms tumor in a person having a horseshoe kidney, and risk of stone formation also. Now, coming to the anomalies associated with the renal malrotation, and it occurs due to the failure of a 90-degree ventromedial rotation, and it can occur with or without ectopia. Now, the first image is showing a normal kidney. The second image is a non-rotation or incomplete rotated kidney, and this is a reverse rotated kidney, and this is a hyperrotation. The ventromedial rotation has occurred, but it has overshooted the 90-degree rotation, and this is a sagittal kidney rotation. Now here, this is a CT image showing a malrotated kidney. The hilum is facing anteriorly, and this is a 3D reconstruction showing the anteriorly faced hilum. The clinical importance, they are usually asymptomatic, may cause hydronephrosis, and they sometimes they are confused with the horseshoe-shaped kidney, and they have to be differentiated with further image with proper imaging. Now coming to the renal vascular anomalies. There are can be multiple renal arteries, accessory vessels, or aberrant vessels. In the embryology, the renal arteries, there is primitive vascular network initially, and the renal arteries developed by selective regression during the ascent. If this selective regression doesn't occur, it leads to the various vascular anomalies. Apart from the then we are now we'll see if the anomalies are distorted, the normal segmental anomalies will not be present in the kidneys. Why the normal segmental? Why it is important to know the normal segmental anomaly anatomy is that the segmental anatomy we know is divided into 5 zones: apical, upper, middle, lower, and posterior. And it is an end artery system. This leads to a relatively avascular line known as the Brodel's line, which is commonly used for surgical puncture as well as surgical incisions in the kidney. If there is anomalies in the renal arterial supply, this anatomy is distorted, and hence it is clinically important. Again, the other abnormality that can occur is an aberrant lower crossing vessel can lead to a EPJ obstruction. Here you can see a 3D reconstructed image showing an dilated pelvis in the green color and an aberrant lower renal artery crossing just below the pelvis, causing this EPJ obstruction. It is important to know during the repair, so we have to cut and ligate these arteries. Now, the other anomalies is the renal artery aneurysms. The incidence is very rare, about 0.01%. And these are mostly secular varieties. As you can see in this 3D reconstructed image, they are classified into 3 types: type 1, type 2, and type 3. The type 1 occurs in the renal artery proper, the type 2 occurs in the renal hilum, and the type 3 occurs inside the parenchyma, this whole parenchyma. The indication for treatment in renal artery aneurysms are if they are greater than 2 centimeters in size, if they are expanding, if it poses a risk during pregnancy, or if they are symptomatic. Usual treatment that is given is an angioembolization. That we can see a coil embolization is being done in this image, and the aneurysms resolve. The other anomalies that are congenitally present in vascular system is renal arteriovenous fistulas. It is again a very rare anomalies. Congenitally, it is less than 25% cases of arteriovenous fistula are congenital, and usually we can see a hematuria associated in these patients and bruit present, and it causes renin-mediated hypertension in these patients, and it can also cause high output failure in these patients. Here it is a 3D reconstruction image. In the left side, you can see here is the renal vein, the lower it is the renal artery, and they are forming this renal AV fistula. Here you can see the asterisks. Now coming to the anomalies of the renal collecting systems. Now the bifid pelvis. It is 10% of the normal variant, and usually the most common variety is the early pelvic division. And they are also usually asymptomatic. Here you can see a CT image showing 2 pelvises with 2 different ureters which are fusing later on to form a single ureter. Again, this is another image showing the same thing. And this is a 3D reconstructed image showing a right 2 different pelvis forming a ureter which is continuing till up to the UVJ insertion. The other anomalies that we can see is a calyceal diverticulum. Now, it is a cystic cavity communicating with the calyces, and it is more commonly associated clinically with stones. And in patients with calyceal diverticulum, 40% of them are on the risk of having stones in later life. And if it can be symptomatic, causing infection and pain to the patient. Here you can see a sagittal image of the CT showing a right side kidney with a calyceal diverticulum, the green arrowhead showing the diverticulum, and the left side kidney also there is another calyceal diverticulum. Now coming to some developmental genetics associated with the renal anomalies, congenital anomalies of the kidney and urinary tract, CAKUT. It is defined as structural developmental abnormalities of the kidney and the urinary tract. The incidence of the CAKUT abnormalities are seen in 3 to 7 per 1,000 live births. It accounts for 20 to 30% of antenatally detected anomalies. It is a leading cause, about 30% of pediatric end-stage renal disease. The wide phenotypic spectrum can be can begin with a mild hydronephrosis to bilateral agenesis. The etiology and genetic contributions in these anomalies are multifactorial. It is both genetic and environmental. 10 to 50% show positive family history. 10 to 30% of the cases explained by genetic mutations or copy number variants. Up to 50% mutations may occur de novo. And genomic imbalances play a major pathogenic role. The embryologic kidney development, the kidney develops from the intermediate mesoderms. The various stages of development are the pronephros, mesonephros, metanephros, and nephrogenesis. The pronephros phase occurs in the 3rd week of gestation, and its function is rudimentary and non-functional. The fate is to regress. In the mesonephric stage, it starts from the 4th week of gestation. It has a temporary kidney, and eventually it regresses. The metanephric stage is starts from the 5th week onwards. It forms the permanent kidney, and it forms the permanent kidney, that is a kidney that is in the adult kidney. And the nephrogenesis stage begins from the 5th week of gestation till the 36th week, and in this phase the nephrons are being formed. And the critical developmental events where these anomalies are happening are the ureteric burst outgrowth from the mesonephric duct. The second is the invasion into the metanephric mesenchyma. Third is the branching morphogenesis determines the nephron numbers. Mesenchymal epithelial transition and renal vesicle formation stage, and the migration and fusion events define the final kidney position this stage. The spectrum of the CAKUT phenotypes range from ureteric bud defects leading to VUR, VUJ obstruction and duplex system, fusion defects leading to horseshoe kidney, migration defects leading to ectopic kidneys, nephron defects leading to renal hypoplasia, dysplasia and multicystic disease, and bladder or urethral defects leading to posterior urethral valves. The key genes that are involved in the CAKUT anomalies are as follows. The transcription factors PAX2, HNF1B, WT1, 6-1, EYA1, and SAL1. GDNF and red pathway regulates the ureteric bud branching. WNT signaling controls the nephron induction. Notch signaling regulates the proximal tubule and podocyte differentiation. Sonic HUA pathways mutation linked to the syndromic CAKUTs. Now we'll see some associated genetic syndromes that is caused by the CAKUT problems. The first syndrome is the renal coloboma syndrome. It is due to the gene mutation in PAX2, and the key features are renal hypoplasia, dysplasia, and VUR. Now the second is the MODY5 renal cystic and diabetes. The gene mutation in this is HNF1B, and the key renal features are renal cyst and hypoplasia. The third one is the bronchio-otorenal syndrome. The gene mutation in this is the EYA1 and 6-1. It leads to renal dysplasia and VUR. The fourth syndrome is the Townes-Brocks syndrome. It is associated with the SAL1 gene mutation leading to renal agenesis and hypoplasia. The fifth one is the Alagille syndrome associated with the JAK1 in the Notch signaling pathway, and the renal abnormalities are the renal dysplasia and hypoplasia. The copy number variants leading to the CAKUT anomalies are as follows. The large rare CNVs greater than 100 kb found in 10 to 15% of the CAKUT cases. HNF1B deletion at 17q12 is common genomic disorder. CKID and ESCAPE studies have shown that HNF1B and PAX2 are common mutations, and genetic mutations heterogeneity remains, and genotype and phenotype correlations are often inconsistent in these anomalies. The clinical implications and future directions in the CAKUT anomalies are: the genetic testing may be useful in future. The PAX2 gene, for PAX2 gene anomalies, we can do an ophthalmic screening. HNF1B mutations, we can go for diabetic and metabolic screening. And for EYA1 and 6-1, we can do an audiological evaluation as a screening tool. In future, we can go for whole genomic sequencing, and CRISPR models and personalized medicine can be given for these anomalies. The final take-home message from this presentation is most of the anomalies are incidental to be diagnosed, and the most common complications that occur are obstruction and reflux, and are the key. The vascular anomalies are important to know for before surgery, and solitary kidney anomalies, we must do a CKD surveillance and management of CKD. Now we'll see some important contribution. Thank you. And this is Bilateral Association. Now we'll see some important scientific contributions. Now he is Guilford Grobstein. He has contributed in discovery of epithelial mesenchymal interactions, foundation of ureteric bud metanephric mesenchyme concept, and he is a key contributor in renal developmental anomalies. Gregory Dressler, he has discovered the role of PAX2 gene and explained the renal hypoplasia and renal coloboma syndromes. Brian Constantini, he has contributed in discovery of GDNF red signaling and explains mechanism of renal agenesis and CAKUT complications. Andrew McMahon, he has discovered the role of WNT signaling in nephron development. And Carl Ernst von Baer, father of embryology, described the pronephros, mesonephros, and metanephros theory. And last, Frederick Henle, he has discovered the loop of Henle and established the nephron anatomy in the kidney. Thank you, everybody. Now I would invite Dr. Shivam sir, HOD, to continue the meeting.
Thank you, Devashish. That last slides were good. It was a new addition in the presentation. I think it's a good thing to acknowledge people who have contributed to the knowledge of that particular topic. So if I may add a few more, you talked about the genetics, right? And those who discovered the various genes related to these problem. Do you know who is called the mother of pediatric pathology? Mother of pediatric pathology. There's definitely a lady, that's why she's called mother. She's Edith Potter. We all know Potter syndrome, right? Potter syndrome is bilateral renal agenesis with Potter facies and all that. The shy infant doesn't survive. So she's called the mother of pediatric pathology. And then there's another lady also, she is called Gilbert Barnes. Gilbert Barnes has described each and every pediatric pathology. She is a great teacher. She has taught generations of students, and her textbook chapters, etc., are related to each and every pediatric pathology that you know of. She is Gilbert Barnes. She was editor-in-chief of fetal and pediatric pathology, right? And now she again wrote a book on Potter syndrome, where the main thing is by Edith Potter herself, and the book is written by Gilbert Barnes. So good to know all these things, the great people who are associated with these anomalies. So coming to the anomalies, CAKUT anomalies, we all know. It accounts for almost 20 to 30% of all congenital anomalies when a child is born, right? So it's a very important group of anomalies that we come across. The incidence is around 0.3 to 1.5%. On an average, you may say 0.5%. And 30% of these CAKUT anomalies have non-renal anomalies associated. That means they have other anomalies along with the renal anomalies. And they account for more than 200 syndromes, right? So he talked about various syndromes, the most important being Bidet-Bidman syndrome, where you have this polydactyly also. So on physical examination of the child, if you find some abnormalities like polydactyly, so if there is ear deformities, right, that goes in favor of bronchio-otorenal syndrome, or also called Fraser syndrome, right? And then there is a renal coloboma syndrome, where there is a coloboma of the optic nerve, and there is problem with the vision. And then there are other syndromes like, as he talked about, Rokitansky-Kusterhauser syndrome. And if there is, suppose, a microphallus or a cryptorchidism, etc., then it may be associated with Coleman syndrome, Turner syndrome, trisomy, etc. And then so there are various syndromes which are associated with these anomalies. So it's worthwhile knowing about these syndromes, because they can be picked up if you do a proper physical examination and investigation. So whenever these patients' symptomatology could be a spectrum beginning with asymptomatic to patient who cannot survive. They are born stillborn, right? So asymptomatic could be many, like duplex kidney, like duplicated ureters, ectopic kidney, horseshoe kidney. They may all remain asymptomatic throughout their life. Whereas patients who have renal agenesis, bilateral renal agenesis, definitely not, the patient doesn't survive. Then renal dysplasia, and other conditions like VUR, vesico-ureteric reflux, etc., ectopic ureters, that and obstruction, all these can really lead to recurrent urinary tract infection as a symptom, right? So many of these patients will have renal dysgenesis, and they may go into chronic kidney disease. In fact, it has been seen that almost 40 to 50% of end-stage renal disease in pediatric population belongs to this group of anomalies, right? So they would require monitoring of their renal function, hypertension, blood pressure, and then, if necessary, they will require renal replacement therapy. Otherwise, most of these patients may present as a recurrent urinary tract infection. Sometimes they may present with abdominal lump. Sometimes the prune belly syndrome, which is so obvious on physical examination. All right. And so once this kind of a thing is suspected, you go into investigation, imaging studies done. The commonest would be an ultrasound to know if there is an anomaly of the kidney. And if necessary, we will go for a renal scan or a MRI or a CT scan. And then monitoring is required of renal function. And then the urine routine examination is also very important in these patients. So many of these patients can present with hematuria also. And they may have microscopic hematuria, they may have albuminuria, right? And So you need to check the urine routine examination, microscopic examination, check the blood pressure of these patients. These are all important. And as he said, the treatment, the management part would remain from rather monitoring the patient throughout their life. And then many of them would require surgical management. And some may require even a renal replacement therapy. I think that was all in brief about the CAKUT anomalies. I think it would be nice if one of us can actually take up this study on the prevalence of CAKUT anomalies in the pediatric population and their outcome and how they are managed. I think if you can volunteer, one of you, I think we can give you one of you this study. So any question, query from residents or faculty or those who have joined us today, they can just put their hands up. Anybody? Yes? Okay. So we will go to the MCQs. Go ahead. So number one, bilateral renal agenesis results primarily from failure of which embryological event? Failure of mesonephros formation, failure of ureteric bud formation from mesonephric duct, failure of pronephric duct regression, failure of cloacal division, failure of metanephric mesenchymal differentiation only. So mesonephros formation, ureteric bud formation from mesonephric duct. Okay. So if the ureteric bud doesn't form, it actually, the kidney doesn't form, right? Okay. Can I go to the next? So failure of ureteric. Ureteric bud induces metanephric blastema differentiations. So absence leads to failure of nephron and collecting system formation and causes Potter sequence in bilateral cases, as we discussed. So the ureteric bud is the main thing which induces differentiation. As ascent of horseshoe kidney is arrested most commonly at inferior, superior, common iliac, median sacral renal vein. So all of us know it, right? Inferior mesenteric artery. Right. So which feature best distinguishes crossed fused ectopia? Best distinguishes. Okay, absence of kidney, absence of ureter, ureter crosses midline, absence of renal artery, contralateral hypertrophy. So very easy, ureter crosses midline and inserts normal. Which gene mutation is associated with renal coloboma syndrome? Right? WT1, PAX2, RET, HNPF1 beta, EYA1. So it's PAX2, PAX2. WT1 is with Wilms tumor. And PAX2 is for renal coloboma syndrome. And HNF1 beta is for is it Beckman syndrome? I don't remember. Anyway, so which confirms true supernumerary kidney? Enlarged kidney, separate collecting system only, separate capsule and independent blood supply, duplex ureter, contralateral hypertrophy. Okay. Most common vascular cause of UPJAO obstruction: accessory renal vein, persistent subcardian vein, aberrant lower polar artery, renal artery aneurysm, multiple segmental veins. So aberrant lower polar artery. So one thing that he made a blunder in his presentation was that the management is you cut the artery and like it. No, you never cut the artery. You have to transect the UPJ and transpose it in front of the artery. You never cut the artery. Renal arteries are end arteries, right? So if you cut the arteries, it will get infarcted. That particular segment will get infarcted. Which pathway regulates ureteric bud branching? SHH, Notch, GDNF, WNT, PMP. C, GDNF, RET. So this regulates the, what is the full form? You must remember, you must know. So this is critical for ureteric bud growth and branching. Okay. So this was, anybody has any other query? Anybody, any other comment to make? Otherwise, we will wrap up the session.